increase the size of that window a little bit to Dr. Mark Farrell, to introduce our speaker today.
Thank you, Stephanie. Welcome, everyone. It's my very good pleasure to introduce our speaker today, Dr. Laura Duncan. I've known Laura for quite some time now, and in fact, she's a fantastic colleague. Dr. Laura Duncan is an assistant professor in the Department of Psychiatry and Behavioral Neurosciences and a researcher at the Alfred Center for Child Studies at McMaster University. She also guides research and evaluation efforts at McMaster Children's Hospital, their child and youth mental health program. She's received a BA from the University of Oxford, an MA in sociology, and her PhD in health research methodology at McMaster University, where she also worked as a research coordinator for the 2014 Ontario Child Health Study, which will be the focus of her talk today. In introducing Dr. Duncan, I asked her to provide a brief bio, and she's just had a remarkable start to her career. And I just want to highlight some of these notable accolades for you all. In 2019, she received an Emerging Scholar Award for her PhD thesis work from the Canadian RDC Network. In 2020, she received an Early Career Award from Hamilton Health Sciences Research, and in 2021, she received the New Investigator Grant, which is a collaborative grant from the Sick Kids Foundation and CIHR. And with this particular funding, her research aims to establish a population health approach to improving the mental health of children and youth through the generation of evidence and measurement tools for the assessment of their mental health needs and the planning and provision of services to address these needs at an epidemiological level. Dr. Duncan, it's great to have you here. Thank you very much for speaking to us today. I will invite individuals to ask their questions, perhaps reserving them for the end of the talk. But if, Laura, you're comfortable in receiving questions during your talk, I'll leave that decision up to you. Thank you very much, everyone, for attending. And Laura, on to you.
Thanks so much, Mark. And thank you for that lovely intro. I kind of want to crawl under the desk, especially as it took me like 10 minutes to get WebEx working, which is just so embarrassing, but thank you. Yeah, I'm definitely open to questions throughout. Please jump in. I can't see anything with folks if you're putting hands up or stuff in the chat, so please do feel free to jump in. But yeah, aware of the time, so I will just jump right in. So it's a pleasure to speak to you today about my research using the Ontario Child Health Study data, and in particular focusing on work using data linkages with the Ontario Child Health Study data and looking at child and youth mental health need, service use, and resource allocation. So this work I'm presenting today is a team effort, and here are the folks that have been involved in the work to date, as well as the larger Ontario Child Health Study team. So they're noted here on the slide, and also recognizing the funders and supporters of this work to date. So I'm trying to outline here the position that I'm approaching this work from so that you have some idea what the kind of driving force is behind this work. So it's kind of captured by this quote. This is psychiatric epidemiology should become more central to mental health service planning. I think most people can agree with the sentiment that we should be using psychiatric epidemiological data as part of our mental health service planning efforts. But in reality, it's really difficult to figure out how we do that. And then actually doing it is really, really difficult and really complex. And what I'm starting to learn is that there's a lot of things that people assume that we know about collecting and using data for planning and resource allocation in this context, but that we actually don't know, and we really do need to know. So this is kind of the driving efforts behind the work that I'm presenting today. And my research goals really kind of encompass all of this, which is the idea of developing systematic approaches to collecting child and youth mental health epidemiologic data, and then exploring and testing ways that this data can be used in service planning, and then quite broadly thinking about evaluating the principles of equity and accountability that are meant to drive health systems and the way that we distribute care and respond to needs in our population. So I'm going to focus on, one more. So this is kind of the outline for the talk. I'm going to kind of give some information on the rationale, design and features of the 2014 Ontario Child Health Study, just to provide some inspiration to use and access of the data. It really is a unique data set, definitely in Canada, and I actually think potentially anywhere. And I think when you learn a little bit more about the methods, you'll see why that could be the case. And just know that I use OAKS to refer to the OCHS. So you'll hear me saying the 2014 OAKS or the OAKS data, and that's kind of what I'm referring to. There is more information about the Ontario Child Health Study in a special issue that was published in the Canadian Journal of Psychiatry in 2019. So if you're interested in reading more, there's a methods paper there. There's some kind of policy implications papers and other substantive papers in that special issue. So I'd encourage you to go and hunt that out. So after doing that, I'm going to outline some key findings with a focus on analyses using linked data. And I'll go through these pretty quickly as the work is published, and so you can kind of get into it further by reading the papers. And they do use linked data at the aggregate level. And then I'll spend a little bit more time on some more recent work using the linked administrative health data at the individual level, looking at the estimation of mental disorder prevalence. So first off, with the design of the Ontario Child Health Study. So we know the importance of mental health in children and youth. We know that 1 in 5 children and youth will experience a mental health disorder. It's the #1 cause of disability, and it relates to high costs and burden amongst the population. Researchers and policy decision makers need access to up-to-date estimates of disorder prevalence, service contact, unmet need, group differences in prevalence. And so with that in mind, the Ontario Child Health Study had kind of 2 primary areas of focus. So the first was around the epidemiology of child and youth mental disorder and mental health service use. And the second was around the socio-contextual determinants of child and youth mental disorder, in particular neighborhoods and schools. And this image here just outlines the framework of this kind of contextual effects that we were interested in. And I'll walk through the design. And as I said, more detail is available in the methods paper. The sampling frame was the Canadian Child Tax Benefit File, which is kind of the most complete listing of families with children in Canada. Our target sample was 13,000 households with children aged 4 to 17 in Ontario. It used a probability sample, multi-stage stratified cluster design, and our response rate was 51%, which is pretty good going by today's standards. But when we compare that to how the 1983 OAKS managed at 93%, we just have lots of jealousy and envy about how great their response rates were. And with Statistics Canada data, you know, we're relying on them to calculate survey weights that correct for these issues with response rates that just seem to be getting worse and worse when we're trying to do general population surveys. So the primary sampling unit for the Ontario Child Health Study was areas made up of grouped contiguous census tracts and dissemination areas. And I won't get into how that happened, but it was quite complicated and ultimately ended up being that we had to group these areas into bigger clusters in order to have enough people within them to look at contextual effects. And these primary sampling units were stratified by income and also by urban-rural status. And then on average, we sampled around 75 households per PSU, again stratified by low, medium, and high income. Within families, we sampled 1 to 4 children. We had 1 child that was the target child, and we collected kind of a really comprehensive set of data on them, but then we also collected information on up to 3 siblings, and that was a little bit of a reduced set of information. And then we also collected information from a spouse partner if there was one present, and also a teacher of elementary aged children. Children were also embedded in schools, and Kathy Georgiades led a partner study called the School Mental Health Surveys, which sought to characterize the schools that the kids in the OAKS were in. And so through kind of a complicated matching of postal code information from Statistics Canada of the respondents that had been selected, we tried to figure out the schools that would be included in the study, and we went out and sampled them at the same time. We also had data linkage that occurred at the individual level. And so this will be some of what I'm talking about today. We individually linked with Ministry of Health administrative data, particularly the DADS, the NACAs and OHIP billings files. And we also have some Ministry of Education data, report card data, some of the EDI measures and programs and services received within the school. So that's at the individual level. And then we also did some area level linkage at the DA and CT level from the census, and also at the census division level, we accessed some information about government expenditures. And that's a lot of what my work is focused on. So in total, the sample looked like this. So you have the Ontario Child Health Study on the one side of about 10,800 children within 6,500 dwellings in 180 neighborhoods. And then at the same time, we had 248 schools, of which some of the Oaks kids were attending. So some of the 10,800 children were in those 248 schools. And amongst them, we also sampled 30,000 students, 3,000 teachers, and 206 principals. So this is why I say this study is unique. Like the way it's kind of matched together and everything sort of happened over the same time period. I can't think of other examples where studies have done that. So I'm just going to run through the study's kind of unique methodological features and what advantages that brings to you as a researcher in case it kind of, you know, motivates you to work with this data. So we used clustered sampling, and that allowed us to look at contextual effects. So within the sampling, when we were using the income stratification, we wanted to make sure that we had, for example, low-income households in high-income neighborhoods, but then also the converse, where there were high-income households in low-income neighborhoods. And we basically wanted to make sure we had all the cells filled so that we had representation across those groups. And sorry, this is more relevant to the second point, but around the clustered sampling, that was where we had children embedded in families, embedded in neighborhoods, allowing us to look at contextual effects. And the income stratification allowed us to look at SES inequalities. We also had multi-informant data, which just leads to reduced measurement error when you have multiple informants on one child, for example. The linkages with administrative data allow us to look at health system and service use. And then linkages with school climate and resources data, we can kind of try and parse out the impact of schools and the school environment on mental health, because we know that that's important. And there is, if you open a code book for the Ontario Child Health Study, you'll feel like you've been hit over the head with more concepts than you can possibly imagine. So all that means is endless possibilities of research questions. And there is so much in there that has yet to be looked at that I would encourage you to go and take a look. And as inspiration, here are some examples of research questions that have been addressed or are being addressed with the Oaks data and the people being people leading this work. So prevalence and correlates of suicide ideation and attempts in youth, do levels of neighborhood poverty and antisocial behavior modify the association between household poverty and child-youth mental health problems. So this was an example of being able to look at contextual effects and multi-level modeling. Is there a joint association between family-level inadequate housing and neighborhood-level antisocial behavior with child and youth mental health problems? And then what is the prevalence and correlates of mental health service sector contacts in children and youth using linked survey data? So if we actually go to the administrative health data, what can we tell about contacts with mental health services? So that was a very quick overview of the data itself, and we're going to dig into some of it a little bit more. So I'm now going to talk about some key findings resulting from analyses that use linked Oaks data that tell us about child and youth mental health need, service use, and resource allocation. So to do this, I'm going to run through two projects. The first looks at area level variation in child and youth unmet need for community-based mental health services. And the paper that this is attached to is just shown there. And then the second looks at the alignment between child and youth mental health service expenditures and child and youth mental health need. So in order to kind of understand these projects, it's important to know about how child and youth mental health services are organized in Ontario and what we mean when we say area, because I'm interested in area level effects. So this is how the case was in 2014-15 when the Ontario Child Health Study was carried out. And for the most part, it's largely still true. It's just that the funding now flows from a different source. So if we think about children's mental health service providers, you've got government funded services on one side, non-government funded services on the other, and the majority land in the government funded services. And so within them, there were 3 ministries responsible for providing services when the study was conducted. So you've got children's mental health agencies that are in the community, youth justice services and child welfare, and they fell under the Ministry of Children and Youth Services, which doesn't exist anymore, but it was MCYS. And so you'll hear me referring to MCYS. And that got moved to the Ministry of Health. So that's the change that has happened since the study was conducted. And then with the schools, you've got the Ministry of Education that kind of governs school services. And then physicians and hospitals fall under the Ministry of Health and Long-Term Care, or the Ministry of Health as it is now. So my focus is on MCYS as it was known. And so right now, the way that they are organized is exactly the same way as they were organized in 2014-15. It's just that the funding now flows from the Ministry of Health instead of flowing from MCYS. So MCYS or the Ministry of Health allocates resources to individual service agencies in Ontario. And these service agencies are in 33 service areas and 5 regions. And this map just shows the different service areas and the regions that are involved. They're based on census divisions, so it's nice that they have a tie with census geography. There is no clear allocation process for getting resources to these agencies. They have played with the idea of a funding formula, but it's not clear exactly how how money flows and how it's allocated to individual agencies. The 2014 OAKS had questions in it that were designed specifically to ask about interactions with MCYS agencies. So we provided respondents with lists of agencies in their area and asked them to kind of identify them by name, or just use that list as a prompt to give them an idea of the types of services that we were asking about, to really try and be able to parse out those agencies from interactions with, say, a physician or a nurse or a psychologist in another setting. So some key definitions in understanding this work. So unmet need is the extent to which children that we determine to have a mental health need. So this could be, we either assess them for a disorder or a certain level of symptomatology, or we ask them if they perceive that they have a need for professional help. But it's the extent to which those with a need are not receiving community-based mental health services, and that's how we're defining unmet need. The evidence on between area variation in service arrangement, geographic and population characteristics associated with unmet need is very limited, which is kind of what motivated this work. And any work that has been done tends to rely on kind of ecological approaches, which we know are subject to criticism. So the advantage with the Ontario Child Health Study data is we had a whole bunch of individual level data that we could tie to service area level data, and our individuals are nested within service areas. So the questions that we sought to address was, what proportion of children and youth have unmet need? Does that vary by service area? And then are there characteristics that are kind of linked with lower levels or higher levels of unmet need? So things that we think might be associated with lower unmet need are greater service expenditures. If there's more money, does unmet need go down? If there are more service agencies, is there lower levels of unmet need? And then things that might correlate to higher unmet need would be rural areas, areas with poor public transport, or areas with higher levels of SES disadvantage. And so these were kind of the questions we were interested in exploring. So we used the individual level OAKS data, and then we linked it to aggregate service area level data that came from administrative records from MCYS. So we took the government funding information. We also aggregated together household survey responses from the OAKS. So questions that were answered at the household level, we aggregated up to the service area level. And then we also use some census profile data, again at the census division level. And we did a simple cross-classification of mental health need by service use, and then a series of multi-level random intercept binary logistic regression models of child and youth unmet need at level 1 nested within service areas at level 2. So this just shows you we had around 10,700 children in our final sample nested within the service areas and the basic characteristics of these children and areas. So looking at the numbers of children with and without need who have and don't have contacts with mental health services, we end up with this kind of cross tabulation. And in this, looking at this, mental health need is defined using both a validated tool where we're using a standardized diagnostic interview to assess whether a child has a disorder or not. But we also included self-reported perceptions of need because we know that both of these can drive service use. It's not, you don't have to have a disorder in order to use services. And we know that in some cases, just that feeling of crisis and a perception of need is what's going to lead you to use services. And then on the mental health service use side, this was using those questions that I said were designed. They were actually created by Graham Reed and Juliana Tabon based on some work that tried to increase the validity of self-reports of mental health service use. And so that was those questions that we used. And so we found that 16% of children and youth had an unmet need, according to our definition. So to what extent did this vary by service area? So here we're just calculating the random effect in our model, which gave us an ICC of 0.016. So what that means is that 1.6% of the reliable variance in unmet need is due to between service area differences. So that sounds small, and this is a problem with kind of looking at random effects is the ICCs do look small. And so there has been some guidance here that I list about interpreting ICCs and kind of relating them to effect sizes. And so what you see is that if we have 1.6% of reliable variance, it puts us kind of between an effect size of 0.2 and 0.4. So we consider this to be a small but meaningful effect. So this is a residual plot that can help you visualize variation across areas. So what we have here is unmet need plotted across the different service areas. And so you can see how far service area estimates of unmet need are from the overall mean. So that line across the middle at 0 is the mean level of unmet need. And then you've got kind of the ranking from Toronto, which is the lowest level of unmet need on the left, and then Halliburton, Kawartha Lakes, and Peterborough, which has the highest level on the right. And I put in there Waterloo and Hamilton as well. So Waterloo is kind of right around the average here, and then Hamilton over here with slightly higher levels of unmet need. So these are the results of the multi-level models, and I'm just going to summarize instead of getting into the numbers. But in summary, high levels of unmet need were found in rural areas, areas with fewer service agencies and unsatisfactory public transit, as we expected. And then we found lower levels of unmet need in Toronto. Toronto stuck out like an outlier, so we ended up including it as its own variable because it just has so many more agencies, so much more money, and has such lower levels of unmet need. And also areas with higher average household income. So kind of the things that we anticipated seeing, we did actually see play out in our results. So strengths of this work is it does address some of the limitations of ecological analysis that have happened in the past. It's a large sample. We've got multiple sources of service area data. But on the limitations side, we didn't have coverage of all service areas. So I think we only had 28 out of the 33 service areas in there. We also don't know the actual usefulness of this administrative geography. So sure, there are census divisions, but is that meaningful when we think about how agencies are organized? So the fact that census divisions do drive the service areas that MCYS uses, there are lead agencies in each of those areas that kind of monitor the agencies across that group. So we would hope they are kind of meaningful, but that hasn't actually been evaluated in any way. So we don't know that it is actually useful. We just hope that it is. And linked to that, you know, families don't have to seek services in the service area that they live in. So they could have gone elsewhere, they could have gone next door. And we did look at that and find that there was a small number of people reporting service use in other areas, but it was hard to actually quantify it in the data that we had. And also it's hard to, I have to kind of caveat this with the changes that have happened to MCYS, even though I think organizationally there aren't any substantive changes. There are governmental and administrative changes, and so the implications of this kind of change as the service landscape changes. Okay, so that was a quick tour of that one. So now a quick tour of the alignment between service expenditures and need. So we're using a lot of the same data sources again, but this time kind of looking at how well services align with needs. So we would kind of like to think that the way that service agencies get their funds kind of lines up with the level of need that exists in an area. So if we find certain areas have more or less need, that maybe there's an adjustment in the funding or the resourcing that would allow that kind of alignment to enable provision of more services. So at a basic level, comparing need with allocations, here's a comparison of 1983, which is when the original Ontario Child Health Study happened, and 2014. So in 1983, you can see that if we look at need as a percentage of the number of children with at least one mental disorder, and then allocation as dollar per child, there is variability between need and the amount of money that gets given. So here we've got similar levels of need in central and southwest regions with different per child allocations. And then 2014, we see the same thing. So in Peel and in Halton, similar levels of child mental health need, but different levels of per capita allocations. So in order to figure out the extent to which expenditures were allocated according to need, what we had to do first was develop what we called an equity funding formula based on need. So this was the idea that if we think there is some equitable allocation that exists, what is that? So that then we can compare those actual expenditures with this hypothetical equitable allocation. So we had to sort through what that would look like and what that would mean based on need and some other factors. Then we compared these allocations based on different definitions of need. As I mentioned with the previous presentation, there are different things that drive service use. We don't fully agree on how mental health needs should be defined. And so we actually incorporated and compared two different definitions. So one on kind of an objective assessed version of mental health need being disorder, and then another one on the more subjective perceived idea of need, just to see what the differences would be. And then finally, we calculated the percentage of the dollar allocation that would need to be reallocated in order to achieve a situation of equity. So this is kind of an idea of how far are we away from the perfect situation when we have an equitable allocation. So I could spend the whole hour going into how we developed our funding formula. Actually, I'd probably just need the whole day. It was mind-boggling, and we had some critical input from health economist Stephen Birch at McMaster, who was very, very helpful trying to fit this, sort this out. But at a basic level, it's the idea that we would expect funds to be equitably allocated if there are you know, X amount of kids in this area, then there's some per capita amount that should get administered at a very basic level. But then you want to tweak it based on, okay, well, not all kids are going to use services and not all kids are going to need services. So what we did was try and take into account levels of need in the areas, levels of service use in the areas, the number of kids in the areas, and then actually what expenditures you have available. So we took the actual expenditure amount and tweaked it around into an equitable allocation. So we didn't change the allocation, we just made it equitable based on these factors, and then did a comparison with what the actual expenditures were. So these are the results, and I'm just going to explain to you what you're looking at, because all this is just a bar graph right now. So these are the different regions that were covered in this analysis, and these are the individual service areas. So for each service area, there are 4 bars, and the black one is the actual MCYS dollar expenditures. The white one is population based, so that's purely based on the number of people in the area, which we would hope, at a basic level, we would hope that funds are allocated according to the number of kids in the area. Then the assessed needs-based allocation and the perceived needs-based allocation in the 2 other bars. So if we go back to the graph, then what you see is in black, an actual allocation, and then the other bars are above, below, really far above, some of them close. They're just all over the place. They are very different. They vary, and they vary in different ways to each other. So there didn't seem to be a consistent pattern with how these allocations compared to each other. So to help quantify the difference, this is when we looked at what is the percentage of MCYS dollars that would need to be reallocated to achieve equity. So for example, how much do we need to move the money around to bring the black bar in line with these other bars? And so if you use a population-based approach, it's about 30% of the funding that you need to reallocate. And then for assessed needs, 25%, perceived needs, 20%. So it changes depending on your understanding of mental health need. So what we concluded from this is that the distribution of MCYS dollars is variable and doesn't seem to be aligned with anything that we could tell from our model, but also not aligned with what we considered to be an equitable allocation. And of course, you can come at me with all your arguments about why our equitable allocation is not. Like, I completely agree that there are lots of assumptions behind our funding formula, but I think we really tried to think that through carefully and sensibly. So, but I found it a fascinating thing to kind of work through. And so some reallocation of funds is needed to achieve equity. So the strengths of this work was we evaluated different definitions of mental health need, but we did see differences in our results depending on our definition. So that has important implications for how we understand mental health need when we're thinking administratively about how we make policy decisions and how we allocate funds. In terms of limitations, for this, we were even more limited on the number of service areas that we can include. So in the end, we only had 13 out of the 33 service areas. One thing that is a problem with this cross-sectional data is you can't disentangle the relationship between levels of need and impact of services. So if you think about if you have a mental health need and you're seeking out a service, that there is some kind of timeline about being at the height of need and then accessing services, and then maybe your need drops off. Ideally, your need drops off. But there could also be a situation where your need is low because you're actually in services already or you've received services, and we don't have a way of picking that up in the study. So we do recognize that as a limitation. The equity formula focuses only on need as kind of a key definition, as well as population counts. But you could argue that there are other social indicators that should be in there. And, we had intentions of looking at other types of kind of indicator work for funding purposes. And I think that there's lots more to do in that area. We're also making some key assumptions about what drives service use, how we define need, and also the effectiveness of services. We're saying here that services are good, go get service, and we're not saying anything about, maybe there are situations where services are not effective, and we don't really go there. Okay, so if everybody's good, we're going to now move on to talk about some kind of new findings that use data linkage at the individual level. And this is comparing administrative health data and survey data in the estimation of mental disorder prevalence. So if I go back to my slide from earlier, I said that researchers and policymakers need access to up-to-date estimates of prevalence, service contacts, unmet need. And you've seen how I've used these estimates so far in the projects that I presented. They're really important numbers for planning, for understanding how people are interacting with services based on their levels of need. And we should have ready access to this information, but we just don't. And we continue to have a real lack of data in this area. And there are lots of researchers advocating for collecting this data more systematically. So it's possible to get these estimates from surveys like the Ontario Child Health Study, but increasingly administrative health records are also used, and there are pros and cons to both approaches. So with general population surveys, often the measurement is strong. We're often using a standardized assessment. Random sampling approaches, we have detailed SES information. Our surveys include service users and non-users. But on the con side, they don't happen very regularly. They're very expensive. As we discovered, response rates are going down, and often there is incomplete geographic coverage. Whereas with the administrative health records, it includes everybody who comes into contact with a health service. It has a comprehensive coverage of like all the possible numbers and types of diagnoses. It's collected routinely, but on the disadvantages, it has no standardized or validated approaches to classifying disorder. There is minimal, if any, socioeconomic and demographic information, and it excludes those with disorders who aren't using health services. So you are missing a group of folks when you're just looking at administrative health records. So the purpose of this work was to look at how data sources compare for the estimation of disorder prevalence in service contexts. And there has been work in this area among adults, but not in children and youth. And the adult research found that there were differences in prevalence, low concordance between classifications, and discrepancies between self-report service use and administrative records, which is a total spoiler alert for what we found with our work. So our objective was to evaluate the differences in overall and subgroup estimates of disorder by answering the questions that I'm showing here. So are disorder prevalence and service contact estimates different by data source? What is the level of agreement? So at the individual level for one person, do they agree on disorder classification based on the survey and also in the administrative health record that we linked to? And are there differences in the patterns of population subgroup estimates between age, sex, and geography? So this is the idea that, okay, maybe we don't get the numbers exactly right, but are the general patterns of where prevalence is higher or lower between different subgroups, do those patterns stay the same? Like, can we retain something similar? So this is the same data, a slightly smaller sample because these folks had to give permission for their data to be linked with health records and also shared with researchers at McMaster. So a little bit of a smaller sample, but still pretty good. For the mental disorder in the survey, our measure included the mini-KID, which is a standardized diagnostic interview based on the DSM. And in the administrative health data, we were using ICD-10, 9 and 10 codes. And we went through a harmonization process to try and get the disorder selection as similar as possible. So where were the disorders with the greatest chance of being able to assess them in both sources of data? So the final disorder selection was emotional disorders made up of mood and anxiety, and attention deficit hyperactivity. So right there, we see a big limitation. There's only a very few number of disorders that we can get at with both sets of data. And we also had an any disorder category. And then for service contacts in the survey data, we asked parents a series of questions about different providers and settings that could be tied to physician-based services. So we really tried to parse out just those groups that were interacting with hospitals, physicians, walk-in clinics, urgent care, that kind of thing, and different providers as well. So we tried to like really capture every possibility and tie it back to a Ministry of Health provided service. And then in the administrative data, of course, it's any entry in the file shows that there was a service contact. But we did anything associated with a mental health related diagnostic code, and that went beyond those 3 disorders that I mentioned above. So it was a much broader inclusion of disorders. So in order to answer our research questions for our analysis, we basically estimated prevalence and then compared the differences and calculated prevalence ratios to be able to quantify the differences, the size of the difference. We looked at sensitivity and specificity and kappa for levels of agreement and interpreted levels of agreement based on the criteria there in the purple box. And then to look at differences in the patterns, we calculated subgroup estimates amongst age, sex and geography groups, figured out where we had significant differences, and then counted the number of times that was replicated across both data sources, because that would be an indication where you've got a matching pattern. And that's what we were trying to see if we had there. And this is just a slide quickly on the sample characteristics that we had. So here we have the results looking at disorder prevalence and service contact estimates. So you can see here that we've got differences in prevalence. The bolded numbers are statistically significantly higher, with higher prevalence in the survey data, except for mood disorder. So the bolded numbers on the left-hand side here, except for mood disorder, where we see a higher prevalence just slightly in the administrative data. And the ratios quantify how much larger estimates are in one data source versus the other, and they're highly variable. Like they go from like 1.7 up to 10, which just shows you how different they are. In terms of agreement, looking at sensitivity, specificity, and kappa, we've got the interpretation of the level agreement there down on the right-hand side. So agreement ranges from slight to fair, with 1 moderate being service contact. So agreement, it seems to be when you group the disorders, your agreement gets better, and service contacts does seem to be estimated better than disorder. But this just shows you how low the concordance is on the one-on-one agreement between the survey data and the administrative data. So again, our objective here was to look at whether differences in prevalence patterns were replicated across data source. So I'll just walk you through this for the age group results and then show you the full results. So what you see here is for 2 age groups, so 4 to 11 and 12 to 17, what are the differences in prevalence? And the significant differences are bolded. So they're these ones. But you can see that for each one, these significant differences aren't replicated in the other data source. So in the survey, we find higher levels of mood amongst the higher age groups, but we don't see that in the administrative data. And that's the same for each of the findings. There's no replication across the data source. So when we do this looking at age, sex, and geography groups, we can see that that's the case for most of our results, with the exception of ADHD and service contacts, where we do see a replicated finding. So we see that males have higher prevalence of ADHD and service contacts in both the survey data and the administrative data. But when you look a little bit closely, what you see is that even though the relative differences were the same, the prevalence estimates are still extremely different between data sources. And so that kind of leaves you leaves me with questions still. So we found differences in prevalence and patterns by subgroup, slight fair agreement in classifications, groupings more aligned in individual disorders. Differences were varied and inconsistent, which makes it difficult to draw conclusions about potential systematic biases that exist in the survey or the administrative data. And relative subgroup differences were not maintained. So this kind of begs the question about, well, which data source should we use? Which one is more accurate or reliable? And I mean, we didn't set out to answer that question, but have some thoughts about sorting this through. For disorder, we know that the survey uses a validated standardized diagnostic interview, and there is evidence that shows that administrative data is subject to reporting bias and inaccuracies. So maybe the survey is a better way to assess that. And then in the service context, we know that the survey is self-report, which is notoriously unreliable, even though we made our best efforts to increase the reliability and the validity of it. But there are still kind of problems with that. So the administrative data maybe is a better source of trying to understand who at least had contact with the Ministry of Health Services. I feel like we tried to reconcile disorders and contexts as far as possible. Like we tried to give things the best chance they could of matching, but despite our efforts, the differences remained. So some researchers have called for the synthesis of multiple data sources or combining multiple data sources, and these folks listed on the screen have some suggested some methods for doing that. It's not clear that this approach would be useful for looking at between group differences, but it seems like grouping disorders is going to be helpful, and also trying to link wherever you can to another source of information is going to also be helpful. And I just think we have to be really clear about our data sources when we're reporting on disorder prevalence and service contact. So this was the first comparative study in children and youth that used a large linked representative sample. We had the same health jurisdiction that the survey and the administrative data covered, and we had access to all available health records. In terms of limitations, it does just look at Ontario, so this isn't going to reflect the situations in other provinces, although we feel the findings would likely generalize, just because the way that disorder is classified is similar across provinces. We know that the burden of mental disorder is more complex than just diagnosis, so this is kind of a simplified interpretation. And we know that there are informant differences in survey data. So whether we refer to the parent or the youth for their information is going to impact the level of prevalence that we see, and we're not really taking that into account here. So I think more work is needed to understand what happens when you use different informants. So I've just got a couple more slides. I know I'm going to wrap up soon, but I had I put bonus episode. So there's some work we're doing right now and some challenges I'm dealing with, and I was like, maybe there'll be economists in the room that can help me. So I'm just going to quickly outline what we're doing right now, and then I'll stop. So one of the things we assume we know about is expenditures for mental health services for children and youth. And I don't actually think we have a good estimate in this province, at least, for what money is given to child and youth services. And also, we don't know whether it varies by sector. So is the split between Ministry of Health and Ministry of Education the same in different areas on the services that are provided, or do they kind of balance each other out? So if Ministry of Education is doing more services, is there less on the health side, and vice versa? So what we've tried to do is get money information from the different ministries. So from MCYS, we have government expenditures, but from Education and Ministry of Health, the best estimate they could give us was full-time equivalent of staff resourcing, which is, I sat down with policy folks when we did this request, and we really tried to sort through what is the best proxy for resources. If you can't actually get a dollar amount, what is the best thing that they could share? And in both cases, it was FTE. And so now I'm in this bind where I'm trying to translate these FTE amounts to dollars in some reliable way, and I'm kind of stuck. And also just, you know, maybe there is no valid way to do that kind of translation, and it's better to actually stick with kind of some FTE allocation. But anyway, if anyone has any amazing ideas about how to do that, I would really appreciate chatting with you. So then as a final word, then just to gather all this stuff back up together again, really the way that I've tried to capture my work is using these data linkages to leverage the value of the epidemiologic data that we collected in the Oaks. So some of my work is around developing systematic approaches to actually collecting this data within children's mental health agencies so that we have more ready access to it, but then also trying to find out how we can explore and test ways that the data can be used once we've got it. So we've got it, how do we use it to plan? And so that's what some of the stuff I presented today shows. Again, evaluating principles of equity and accountability, and really trying to motivate future child and youth mental health services research. There isn't very much done in this area. It's important. I mean, looking around us right now, boy, it's important. We need to do more. And ultimately trying to improve the ability of child and youth mental health services to respond to the needs of children, youth, and their families. So with that, I will close. And if you have any thoughts or follow-up questions, please email me. And there's some websites of interest here. And yeah, I'll stop there. Sorry, I went very fast. I was trying to make sure I was finished before 2 still, even though we started late. Probably all just heard me gabbing.
Thank you, Laura. I didn't see any questions during, I didn't see any hands raised or comments in the chat box. There. Oh, no, we have some. Okay. Kieran, please feel free. Anyone, feel free to unmute. It's kind of a informal seminar, so feel free to unmute.
Hi, thank you so much for such a great presentation. And I have one question. Like, since the administrative data, they are hard because they're hard to work with. Since how did you define socioeconomic status? Because I am working with administrative data myself on one of the project. And the difficulty which I'm facing is that individual level data for socioeconomic status is not available. So you have to use Ontario marginalization index for all that. So what did you do regarding that issue?
Yeah, so we didn't. So the only stuff that we took from the administrative health data were the classifications of disorder and service contact. And then we relied on the survey data to be able to characterize the population for exactly the reasons that you're saying.
Okay. And about the mental health issues, like you did conducted a survey and you did use ICD-9 and 10 code. What type of mental illnesses did you capture from the administrative data using those codes?
So we actually use DSM-based disorders in the survey. And then it was ICD-9 and 10 in the administrative health data. So that was that, when I said we kind of did like a harmonization process, we basically went back to the underlying classifications and looked to see where they aligned. And the only spots that they aligned was mood disorders and ADHD. And then apart from that, there are things that exist in DSM that don't exist in the administrative data and vice versa. So we tried to pick disorders that were consistent across both sources, but that is a problem that we had to deal with. We didn't classify disorders based on ICD in the survey. So we had to kind of make them fit together that way.
Okay, because I am looking into OMHRS right now, and there are lots of variables available in that. I'm facing difficulty how to define mental illnesses. Like, do I have to derive my own definitions based on ICD-9 and 10? Yeah,
so we, because this is child and youth, like I wish the OMAs existed for children and youth, but it doesn't. But for the children and youth, we went to the ICES mental health and addictions report card on child and youth mental health disorders, and we looked at their definitions of disorder, and they list out their ICD codes that they included. So we started there, but then we went through the ICD-9 and 10, like you can access the encyclopedia kind of thing online, and we went through that and did exactly what you're saying, like sorted through what did we consider to be mental health disorder. And then as an appendix in the paper is a table that includes everything that we considered to be mental health disorder. But you're right, there are tons of them, and some of them live in other disorders, so you have to kind of be really comprehensive about where you go. And honestly, I don't know what that looks like in the adult world either.
Yeah.
Good luck.
Thanks. Thanks.
Hey, Laura, it's Mark.
Hello.
Really nice talk. I appreciate it. I've got a couple questions, if you don't mind. The first, and maybe you said this, but I might have missed it. With regards to the agreement analyses, was that based on parent report on the mini kid?
Yeah, I think we constrained it to parent report of the mini kid because it was across the whole age group. Whereas if we wanted to incorporate the youth, whereas either an and or an or, we would have to restrict our age group. But I know what you're going to say next.
Because I'm just wondering if you were to restrict to I think it was 14 to 17, to examine those potential age effects or even sex effects within the self-reports, it might be a useful exercise. I don't know.
No, I think it would be, and I think potentially it's going to make things look even worse because we know the informant agreement is low, and I think you just published something on this, that then, yeah, do we do an and or an or how would we do that? But yeah, actually looking at it might give some indication of whether this is better or worse.
Mm-hmm. And then I guess as a follow-up to that, I'm wondering, you mentioned and you showed the trend that with grouping disorders, there was an increase in the agreement based on the kappa value. But I wonder, is that really just an artificial improvement in agreement? Because we know kappa is tied to prevalence. And if we're going to aggregate disorders, either, internalizing, externalizing, or any disorder, wouldn't we just expect kappa to go up?
Yeah, probably.
Okay.
Yeah.
So I
Yes.
guess I wasn't sure if I was off the mark on that, but it just seemed like it lined so well with textbook examples of the relationship between prevalence and kappa.
Yeah, I mean, I think we could look at levels of prevalence, like we could set a threshold of like what's the lowest level of that prevalence should be. So I know that we dropped, we had a couple of categories in there. I'm just trying to see if I've still got them, that were extremely low prevalence that we did drop for that reason. So I feel like we almost did apply that kind of rule, but that still probably is operating to some extent, just because of the low numbers across some of them. Yeah. And right. we should probably, I think, be clearer maybe in stating that we would expect to see that.
Right.
Yeah.
I don't see any other hands up, so I'm going to continue on this opportunity. I'm wondering, you brought up the original Oaks from 1983. There were 2 follow-ups to that, and then now there's the 2014 Oaks. Any plans, given that you're part of the leadership of the Oaks, that there will be a future follow-up to Oaks? I know initially that was the talk, but I'm wondering if there's now an opportunity, given COVID, to really do another follow-up with Oaks, given all the same measures and things like that.
Mm-hmm. Yeah, we've definitely talked about it, and I think so. A couple things, like Statistics Canada has talked about feasibility as an issue, and I think we know that, like, the last Oaks really only happened because of the additional support from the Ministry of Health. So I think we'd have to look at slightly different ways of going about it, but we have talked about a follow-up linkage, so that we are doing some kind of follow-up with them. But then in terms of the COVID piece, like Kathy has led the group who are going to do another round of the what's it called, the Child and Family Youth, it's like the CHC, Child Health and Child something. It's one of the Statistics Canada studies that was done, and they did it once. And so I think that was seen to be like the best option of kind of having another check-in with people. So I know that that's happening, but we certainly haven't. We are still, it's not off the table.
Okay. Yeah, that child and health study, that recent one, I think it was 2019 or something. I'm hoping it will metamorphosize into the new NLSCY and that we can keep it long term, because that would be fantastic.
Yeah, don't know why they ever stopped that.
Yeah, it's unfortunate. Okay, I've got one more. I'm just going to take this opportunity, and this is a bit of a loaded question, given CIHR news recently. But how do we, and I say we as a community of researchers who use StatsCan data, respond to reviewers who would argue that maybe our data are dated? 2014 isn't all that long ago, and there's a lot of rich data within the Oaks. Yeah, there are other studies of child mental health out there, but the extent to which there were structured diagnostic interviews involved, I'm not sure. Obviously, I'm biased in my response to that, but I'm just wondering what your thoughts are.
Yeah, and this bugs me so much. So I think with the Oaks, I have tried to talk about the fact that we relied on the 1983 numbers for so long. Like, you can find citations of the 83 Oaks numbers from like the early 2000s, and that seemed to be okay. It was like, it's the last best thing that we have. So I think making the case for the fact that it's the best that we have, that is the most recent. There are no alternatives, like being clear that there are no alternatives, or what it would take for there to be alternatives. But the other thing I think that's important is like, it's like, are you looking at things about mechanisms that operate that you don't expect to have that much change over time, versus things like prevalence, where you're actually, outdating is a problem. And so I think, like, knowing what you were looking at, like, to me, that's more about mechanisms between how things work, and kind of conceptual relationships that we wouldn't expect to change that much over time. So maybe it's about actually having that as a specific paragraph somewhere in the grant, that then you're sort of saying there's no good reason to need newer data for this, and even if we did, it would take X amount of dollars and this many years to get it. So this right now is the best that we can do. But yeah, I don't know. Reviewers just seem to not be interested in those arguments.
I appreciate your comment there. I agree with you. Thanks.